Here we go. Good afternoon. Happy Tuesday to everyone. It's 4 o'clock Mountain Time, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast, and Tuesday afternoon only means one thing. It's Fertility with Fink and Friends. I am Fink. You are Friends. My name is Dr. Randy Fink, and I am the Clinical Director of IVF Services here at CNY Fertility, Colorado, and the Medical Director of the Miami Center of Excellence. And it sure is great to be back after a little bit of a hiatus. I was not here last week. I got held up a little bit in the operating room, and things got really slow. And by the time 4 o'clock rolled around, I was still waiting for my surgery to start over there. So things are never a big pleasure when you have to wait at the hospital. And I think the week before that, I can't remember. Boy, now time flies. I don't know if we were here for that one or if that's the one where Dr. Kilt sat in for me. But nevertheless, boy, it sure is nice to see each and every one of you on this beautiful Tuesday afternoon. How's your week been? And how was your weekend? And gosh, how have you been over the last couple of weeks? We had all kinds of exciting things happening here at CNY Colorado. Lots of folks getting pregnant, lots of folks trying, meeting lots of wonderful and interesting people, and just really living the dream, helping people to get pregnant. Today was a very special day because our dear friend Amber had an embryo transfer, and we all have our fingers crossed for Amber, and thanks to Serena for all she did to help Amber get where she is. So let's see who we've got with us this afternoon. We have, I think it looks like Sarah. You were the first one over here on the CNY side to join. Thanks for being here. We have Fatima, hopeful in 2023. Tahana, let's see, Journey to Baby W. We've got Jennifer Stone. We have M2 Theo, I'm probably pronouncing it wrong. Sorry about that. Kay and Kendall and Ashler's Real Estate, Mirko Bear and Lindsay Smoot. Style Yourself 509. That's a good name. I like that one. Hi, XOXO Tinsel 6. I'm going to answer your question there in just a minute. Gosh, who else we have? The Salustio clan has joined us. Hello, Jordan. Nice to see you here today. Emily Mortensen is with us. Marcia in Miami, who is a wonderful soul, happens to be here, and that is a real privilege to have you here, my friend. Hi to Sammy, as always. Oh, there is Mrs. Vince, who heard what I had to say about her and sent some hearts. Is that really Alexis, who is here with us as well? Gosh, we've got Grace, we've got Shauna, we've got Brock Tongue. We have, who was the first? Tori Fresh XO. Tori Fresh XO. You are number one. We've got a couple of different Instagram feeds here. We've got Facebook and YouTube over here in the middle. On that side, looks like Jessica Huffman is here, has her first consult on February the 5th and is so excited. Tamara is here as well. Hey, again, great to see everybody. Let's dive right in, if we can, to some questions here. The first question I saw was over on the CNY side, and that was a question about mosaic embryos. What is a mosaic embryo? And the question was, what are my thoughts about mosaic embryos? Well, in many places, there are a lot of clinics who will tell you that a mosaic embryo should be thrown away. And I would tell you that is a bunch of foolishness. So please, if you have embryos and you have done your treatment in another facility, a mosaic embryo is still a good embryo. And so let me tell you kind of what that means. When we're doing testing on an embryo, that's the PGT, the pre-implantation genetic testing. You know, what we're testing with that is just the portion of the embryo that becomes the placenta. It's not testing a piece of the baby. It's testing a piece of the outer part of the embryo, which is also known as the trophectoderm. And that outer portion of the embryo does not represent the baby itself, but is thought to be, there is some concordancy between what's in the placenta and what's in the embryo itself. But it's not perfect. It's not a perfect system. Sometimes you can have an abnormal placenta with a normal baby, or vice versa. You can have a normal placenta with an abnormal baby. And so when we do embryo testing and we find that that embryo is said to be euploid, and euploid means it's got two normal sets of chromosomes, or 46, and it's either XX because it's female or XY because it's male. That's called a euploid embryo. A mosaic embryo is where instead of two sets of normal chromosomes, basically the way to think about it is that there is one chromosome, one set of chromosomes that appears to have an abnormality in it. Now, what exactly does that mean? Because no one wants to have an abnormal baby, right? People will sometimes tell me, "Oh, I'm doing a PGT testing because we want to have a normal baby," and I say, "Oh, you're one of those people that wants a normal baby." Well, let me tell you something here, my friend. We all want normal babies. That's why, as one of the reasons why we do IVF, we all want normal babies. That's not what PGT is for, and nor is that really what it will tell you. It doesn't have anything to do with who's going to have a normal baby, how healthy that baby or that pregnancy is going to be. It helps us to select which of the embryos are believed to be chromosomally normal, which gives us our highest probability of success with that euploid embryo. And that's a 60% chance of a pregnancy for every embryo that is 46 chromosomes and either XX or XY. Now, a mosaic says that one of those sets of chromosomes is believed to have an abnormality in it, or at least that's what is shown in the placenta. That is called placental mosaicism. A mosaic. You remember what a mosaic is from art history class, if you ever paid attention. It's one of those things where they take the little pieces of tile, different colored little pieces of tile, and they put them all together in in some sort of a design that ultimately makes a picture that looks like a painting. But that painting is made up of multiple little tiles, each of a different color and a slightly different kind of design. Well, so think of that mosaic embryo as having a slightly different kind of design. So the easiest way to think about what that means is, again, going back to the numbers. A euploid embryo gives us a 60% probability of having a positive pregnancy test. An untested blastocyst, and so call it your day 5 embryo that you didn't biopsy and do for PGT. That day 5 embryo gives us a 30% chance of having a baby, or rather of having a positive pregnancy test. So it's 60% for the euploid, it's 30% for the untested blast. Well, with the mosaic, the chance of the positive pregnancy test is 40%. So it's not quite as good as the euploid embryo, but it is still better than the untested embryo. And when that embryo implants, assuming that it sticks, it has nearly a 100% probability of giving you as normal a baby as your euploid embryo does. So in no way, shape, or form is a mosaic embryo something that should be discarded. Now, you might feel better knowing that your PGT report says euploid, because again, that's the highest, and then you don't have to worry about anything. There is a slightly higher risk of miscarriage with a mosaic embryo. But if that embryo sticks, odds are it's every bit as normal as your euploid embryo. There is at least a 20% chance that it's not going to stick as well as the euploid, and that's why that number is 60% versus 40%. But again, it's still a higher probability of a normal pregnancy than an untested embryo. So to say that you should throw away or discard a mosaic is really a mistake. because PGT is just not perfect, and there is a high degree of discordancy between what is said to be abnormal in a placenta and what turns out to be completely normal in the baby. So hopefully that takes a little bit of the stress off. We'd be happy to talk to you about about your situation individually. If you have a mosaic embryo, talk to one of us, because it can be a very scary thing. And when you talk to the genetic counselors, they often try to look at, well, this is a mosaic embryo with chromosome number, whatever, and that's associated with, some serious birth defects. It would be very unusual, certainly not impossible, but unusual to have a a chromosomally abnormal live birth resulting from IVF, because in most cases, those abnormal embryos simply don't implant. You never get the positive pregnancy test. So I hope that answers the question there. And let's see what else we got going on here. Tamara says, what are good midway progesterone and estrogen levels? Also, what are good beta levels for the first appointment with an HCG booster? Okay, so that's a really good question. And we've, I think, talked about this before, and I want to stress this again. The HCG booster, HCG is the pregnancy hormone, and that booster is when you give yourself a little extra HCG in the body, and that's a little shot that you give every day, usually from the time of embryo transfer, and you stay on it. It is metabolized in your body as progesterone. And as you get more progesterone, progesterone is the most important hormone to maintain your pregnancy there. So that's what the HCG booster does. And it is very important. It is very helpful when you have had a natural FET, a natural cycle frozen embryo transfer, or a modified natural. In a medicated cycle, that HCG booster really isn't very helpful. So I typically don't recommend it for people. Just not necessary. It's one more thing and one more shot to be giving yourself that you really don't, who likes getting a shot? So I don't recommend it in that scenario. But what will happen is that when it comes time for your first pregnancy test, well, what's the pregnancy test look for? The pregnancy test is looking for the HCG hormone in your blood. And when we give you that HCG hormone, guess what happens? Your pregnancy test is going to be positive. So you need to be aware of that. That first HCG level is not going to be meaningful to us because it is going to be positive. Usually what we do in that scenario is that we repeat that pregnancy test 2 days later. And in 48 hours, we should have expected to see the pregnancy hormone level double. That's how we know you're pregnant. So that first pregnancy test doesn't really matter what the number is. It's usually somewhere in the teens or 20s. That's typically because we're testing the HCG that you're giving yourself. There is no reasonable way to make a prediction based on that one beta HCG. It is based on the second one, because if the HCG is coming from the pregnancy itself, well, then in addition to the basal amount of HCG that you're getting when you're giving yourself your HCG booster shot, your pregnancy is making HCG. So we will expect 48 hours later to see that HCG level go up by 2. Now, what about the progesterone? In a natural cycle, we look to see that progesterone level is a 10, and in a medicated cycle, we look to see that progesterone level is a 20. So best of luck to you, Tamara. Paige is also here with us, as is Crystal. Hi, Crystal. All of my embryos arrested at day 6. Should I freeze at day 3, my next round? Well, that is a good question, and I think a lot of that depends on sort of what the other circumstances were really with your embryos there. But basically, what that means is that they stopped growing, right? They looked at them at the blastocyst stage, hoping that they will have continued to grow, but they stopped growing. So certainly in that scenario, one good choice is to say, well, I'm just not going to let them go that far. We're going to stop them at day 3. And every day of the week, we would much rather see a day 3 embryo going inside of you, where it has the chance to continue growing, because it wants its mama. It's going to continue growing and may continue growing inside of you, whereas it doesn't grow in our laboratory. So we would always rather see an embryo inside of you than an embryo having to get put in the trash because it didn't grow in the lab. So a safe bet is always a day 3 embryo. At least something goes inside of you. And inside our body, I always say you've got the uterus, you've got the magic sauce. And in that magic sauce is stuff that we can only try to pretend like we have in the laboratory or make believe. The uterus is always a better place than the laboratory. And we furthermore have DNA repair mechanisms in our body that may allow an embryo to grow that might not otherwise grow in the lab. So best of luck to you there, Crystal. And oh gosh, Nikki is here with us as well. Thanks to us, 20 weeks pregnant and everything is going great. You are halfway through the battle, my friend. 20 more weeks till a due date. I see Nikki Layton here as well on Facebook. And can a chaotic embryo be transferred? Well, I'm not sure what you mean by chaotic, but all of our embryos here at CNY are chaotic. Sorry, I couldn't resist that. All of our embryo transfers are chaotic, certainly when you do them with me. We try to add a little pleasantry to the whole experience. I'm not sure what you mean by a chaotic embryo. Maybe you mean an aneuploid embryo. Can an embryo that is known, or at least by PGT testing, has been shown to be not a normal embryo. At CNY, we do transfer those embryos. And I like to tell the story. We had a lady who came to visit us. It's been a couple of months now, but who brought in her set of twins that came from 2 aneuploid embryos that she transferred, 2 embryos that she didn't want to dispose of, that were said to be abnormal, and she put them in, and guess what? They were both in fact normal. So again, that PGT testing business, it's not a perfect system. So you don't want to bet your house on it. All right, let's see what else we got going on here. I'm going to take a look at my side of the CNY here. Emily is coming in on Friday for an embryo transfer. Looking forward to seeing you. Hi, Jordan. In a modified natural cycle, why did they trigger me at a 6 millimeter lining? Will it grow more between now and transfer day? Well, hard to say, what happened there. Ideally, we really like your lining to be minimum of 6.5, ideally 7. But in reality, there is some variation to that depending on the blood flow that's going to your lining. And you're in a modified natural. So basically, you reach a point where the egg is mature. And so if the egg is mature, the follicle is mature, you're going to ovulate it anyway. And so if we trigger you, then we have some control over the timing of your embryo transfer. And yes, it will continue to grow a little bit. And also then as the progesterone starts, because your body will make that progesterone and you're using the vaginal progesterone as well, it's going to start to compact that lining. So we will look forward to seeing you, Jordan, and happy Tuesday to the Salustios. We said, regrettably, Lauren. I love the name. Thank you. Great to see you, BJ Pumping. Hello to the wonderful and talented Jody Hoffman. Nurse Jody Hoffman is formerly the nurse manager here at CMY Fertility, Colorado Springs, and has moved now to be part of the Global Connect team. So if you call on the phone, you may have the great fortune of talking to Nurse Jody. Jody, we miss you something terrible here, my friend. Hi to Haley. Grace is here with her husband, Brock, and Grace says, first transfer in Syracuse this week. Keep us in your prayers. We're going to miss the lovely team in beautiful Colorado. Well, we are going to miss you too, Tongue family, and God bless. Good luck with everything. Oh, let's see what else. I see my wonderful mother, who is known as Bamagal _Al. Bamagal, thanks for being here, Mom and Dad, in the beautiful city of Mobile, Alabama, where I just spent several days along with my little girl. And we had a wonderful trip to visit Grandma and Grandpa and ate some fantastic and wonderful food. And it's so wonderful to see you guys on the broadcast today. So thank you. The Salustiel clan, whom I have mentioned previously, transfer number 5 tomorrow in Syracuse. Dr. Arroyo is now with us in the Syracuse office, and thanks. The body did exactly what it was supposed to do naturally. I love it when it does what it's supposed to do. And I even love it more when I was actually right. Um, it happens occasionally, but most people will never admit it. So what can I do about that? Hi to Lucy Marie and M Wonderland. Nick Betez. I have 12 day 3 embryos frozen with CNY. Should I thaw and test? We'd like to have 2 babies one day, and my AMH is very low. Well, so the first thing is congratulations. You got 12 embryos. Holy cow. That's really a great thing, my friend. That gives you lots of different opportunities. So let's talk about really what that means. And sometimes people say, well, you should have blastocysts. Blasts are a much better thing to have. It is true that a blastocyst has a higher probability of giving you a pregnancy. A blastocyst is an embryo that has grown to, let's say, day 5, day 6, occasionally even day 7. So when it's grown to that point, it has become a little functioning machine. So an embryo that's younger than that is what we call a cleavage stage embryo. And a cleavage stage embryo is a group of cells that's still kind of figuring out how to divide or how to cleave, as we call it. They're dividing, they're figuring out how to grow together, how to keep kind of keep the process going on. Whereas a blastocyst is a little functioning machine. So if it has lasted, if it has made it to the point of being a blastocyst, then we know it has a higher chance of getting you a pregnancy. But is there anything wrong with the day 3 embryo? And the answer to that is no way. There's nothing wrong in the world with the day 3 embryo because, again, for the reasons we just talked about, it may grow in you when it doesn't actually grow in the laboratory. So, what are you going to do with 12 day 3 embryos? Well, you do have some options. One option is to say, well, I'm going to thaw those embryos and allow them to continue to grow. We know that some of them will not continue to grow. And you could make the argument that for those that don't grow, we're letting nature help us to select the embryos that have a higher probability of getting us pregnant. Because if those embryos die off, maybe they just weren't meant to be. Well, so that's one option. The other option is to say, well, I'm going to transfer, more than one embryo at a time. The difference really, and this is what it ultimately comes down to, the difference with having a day 3 embryo versus a blastocyst means that if you've got a bunch of blasts versus having a bunch of day 3 embryos, some of those day 3 embryos wouldn't otherwise survive. And so what we know is that you are likely to have to do more probably unsuccessful transfers with day 3 embryos than you would if you had a bunch of blastocysts. So thawing them and letting them grow, letting some of the whichever ones are going to grow to blast is one way to let nature help you to select the embryos that are more likely to get you pregnant. So it's a tough problem to have, I got to tell you, but it's a great problem to have because having 12 embryos has got to be a bit of relief, wouldn't you say? I think so. Hello to Zenaida, also in Miami. Hola to my friends in Miami and Alexis at the Miami Center of Excellence. Oh gosh, I see all my friends at Ocean Reef are here as well. Hello to Mrs. Bailey in California, anxiously awaiting that positive pregnancy test, my friend. Bits of lovely. Are there any BMI limitations at Colorado Springs? Due to the anesthesia considerations in the Colorado Springs Surgery Center that we have here at CNY Fertility, a BMI of 50 is the highest BMI that we can safely accommodate in our Colorado Springs with our Colorado Springs anesthesia group. Let's see. Allie says we have a 3AA embryo and we're getting ready to do an FET with immune protocol 4. Any suggestions? Okay, well, yeah, absolutely. So the first thing I always talk about in folks who have had unsuccessful embryo transfers before, when was the last time your uterine cavity was evaluated? You should be evaluating your uterine cavity once a year, and that's either with a saline sonogram or a hysteroscopy. Secondly, are you taking the right supplements. The supplements that are recommended in the evidence-based protocol for embryo transfer from the book, It Starts with the Egg. The supplements are a prenatal, and I have some thoughts about prenatals there as well. But honestly, any prenatal will do. Molecular Fertility makes a wonderful prenatal that's available on the CNY website. Prenatal CoQ10, vitamin D, vitamin E, and L-arginine. Those are the things you're supposed to be on for embryo transfer. L-arginine is one I kind of want to put an asterisk by, because it is on the list for embryo transfer. It is actually something that is likely to be and is considered to be harmful for egg quality if you're doing an egg retrieval. So when you're doing your stimulation and you're retrieving eggs, I explicitly don't recommend that you be on anything with the L-arginine. Now, there may be some in your prenatal, and that's okay. These are trace amounts, but higher doses or supplementing with extra L-arginine can actually be harmful. So don't do that. But when it comes time for embryo transfer, 100%. Please be on it. That sounds like you got yourself heading in the right direction there. So we will wish you all the best. Fingers crossed, Allie. Good luck with everything. Hi to Ditch the Diagnosis. Hi to Kirsten and MA4722022. I gotta get that number right, but gosh, my eyesight isn't what it used to be. Would a neuroendocrine tumor cause implantation failures like in the pancreas and liver? Well, it depends on exactly what you mean by neuroendocrine tumor. So something that's like a pheochromocytoma. I just like saying the word pheochromocytoma is one type of neuroendocrine tumor that can cause some really crazy things to happen with your blood pressure and your heart rate and some things like that, which in turn has an effect on your cortisol levels, which can have an effect on implantation. So I suppose it depends on how aggressive that neuroendocrine tumor is, Kirsten. But yeah, that's a good question there too. Hi to Rashmi. Hi to BJ Pumping, who we said hello to before. Hello. What is the purpose of HCG and estrogens for priming? Well, HCG is not something I generally use for priming. In our company, Dr. Verdialis, who is our doctor in the Atlanta Monitoring Center, she likes to use an HCG prime based on some evidence that she's familiar with, but I don't know anyone else who does HCG priming. There's been some limited evidence, some smaller studies that showed that it's an idea that can make a difference. And as far as estrogen goes in a priming situation, so priming, as you may know, is what we do when we give you medications that are designed to help you with things before we start stimulating to create your eggs. Right? So priming is just to get the ovaries ready and to try to improve what we're going to find when it comes time to retrieve your eggs. Estrogen and progesterone, but estrogen in particular, is the language that the ovaries speak. So when we speak in their language, we can increase some of the blood flow that's going to the uterus and to the ovaries. Increasing the blood flow can bring some growth factors and healing factors and tissue factors. It can juice up the ovaries, which may make your recovery of eggs all the better. Typically, if I'm doing estrogen, I also very much like to use growth hormone as well, because growth hormone is what keeps us young. If we are creating more blood supply to the uterus, well, that blood supply needs to be bringing something to the uterus with it. So I'd like it to be bringing a little growth hormone. Again, that may have the ability to kind of be able to stabilize some of our age-damaged DNA, which is always part of the uphill battle with fertility. So let's take a step over to the CNY Instagram side here and see if we can get some questions answered. Hi, by the way, 30 minutes after the hour, we are here for another whole half hour of fun. I am Fink, you are friends, and every Tuesday evening at the same time, we show up here to talk about fertility and women's health and answer all of your questions and just to kind of be here for one another during these difficult times. Speaking of difficult times, we all have our ups and downs. Some days are better than others. Same thing absolutely happens, in our, whether it's at workplace or if it's at home, and certainly in the world around us. If it's not a flood or a wildfire, it's a war. It's people dying for reasons that sometimes are very hard to understand. So what can we do about this? And I like to say this at the close of my program as well, but I'll say it now just as a measure of goodwill. Um, Face life with love. Choose love, choose kindness, choose friendship, and really, to the extent that you can, try your best to choose happiness. Because if we don't actively try to choose happiness, then unhappiness will choose us. And that is a really uncomfortable railroad to be on. And it's a railroad that just travels down its tracks and takes us wherever it wants us to go, irrespective of where we'd like to be. And I think, quite frankly, again, so hard to not let it have its way with us. But if on a daily basis we can try to choose kindness, to choose happiness, um, maybe it makes a difference. If not in our own lives, then the lives of those who are around us. So, hey, that's my 2 cents worth there. Okay. Lindsay Smoot says, any suggestions for add-ons to a second FET after the first ends in an early miscarriage? So, first of all, you may know that my feelings about miscarriage after IVF are that is one totally unfair and crappy thing to have to go through. It is insult to injury. It absolutely, if you look up sucks in the dictionary or in the encyclopedia, if you Google the word "it sucks," one of the things that comes up is miscarriage after IVF. So no question there, Lindsay, and so sorry that you had to go through that. Most of the time, when pregnancies end in miscarriage, it is an embryo factor. We always worry that, well, maybe there is some mom factor. Maybe there was a Lindsay factor involved with this. So when I was in the practice of general obstetrics and would see, 25 patients in a day, and some would unfortunately come in with an early pregnancy loss. The first thing I would always want to emphasize is that you did not do anything to make this happen. It is not your fault. You could not change it. It was destined to be, really, from the moment sperm came together with egg. Because most of these early miscarriages happen because of a chromosomal reason. If it's not chromosomes, then it's something metabolic, it's some biochemical factor, something in the whole chain of events that's happening inside that embryo that is making it not able to survive. That is completely out of your hands. People always ask, could it be, because I was next to somebody who was smoking, or heaven forbid, before I knew I was pregnant, I had a little something, or we had a drink, or we had sex, or I did a cartwheel, or somebody, I got a fender bender, and no, none of that has anything to do with the pregnancy loss. It happens because of embryo reasons, almost always. There are very few cases where this is a result of a mom factor, but it can happen. And that's one of the things that we, certainly help people to look at. People who have had recurrent pregnancy losses, we always want to dot those I's and cross those T's to make sure that we're not missing anything. We want to look under every stone to make sure that there's not something in the body that may be causing pregnancies to end. The most common thing that happens there is that there can be something with either something chromosomes, but again, that's an embryo issue, or something in the blood vessels, in mom's blood vessels, that causes her body to want to create little blood clots to clot off some of the small vessels that are supplying blood to the pregnancy and to the uterus and to the placenta. Um, those are things that we can check for in the blood. But at CNY Fertility, we treat you for that anyway with an embryo transfer, and that's what the blood thinner, the Lovenox, is for, because it increases the blood flow and it prevents tiny blood clots in those little blood vessels that can end up causing the pregnancy to prematurely end. So this really is something, Lindsay, that happened because of the embryo itself. As long as your uterine cavity is evaluation is up to date, that you've done that, and I would look at that, because that is something that we think about, especially given that, okay, so you did an embryo transfer. It might have been a year and a half ago, or even 2 years ago, when your uterine cavity was last evaluated. So ask that question: when was my cavity last evaluated? But as long as you're okay there, I think we can all just know that there will be happier times ahead. There is one plus, only one plus that goes along with having a miscarriage. And that is that we know that the pregnancy implanted. We know that your brain was talking and that your uterus was listening, and that the pregnancy grabbed a hold and was able to start to grow. That means that things work in the system where they're supposed to. So, if there had to be a silver lining, that would be what it is. It is a half a step in the right direction. And again, I can feel pretty confident there, my friend, to say happier times ahead. All right, what else we got going on here? Hi to Miss D. Hi to, oh, I said hi, style yourself before. BK Princess, do you suggest canceling a transfer if fluid is present in the uterus during this cycle? So what that looks like is that we can see when we do an ultrasound that sometimes there is some fluid that's inside the uterine lining. And when that's the case, it can be a sign of inflammation. That it's almost like, if you ever fell and skinned your knee and it gets some like icky kind of fluidy stuff on it. Think about that sort of ick, but inside the uterine lining. Ick is the medical terminology for it, if you're not familiar. And it makes a noise too. Are you familiar? You have to listen really carefully, but it goes, eh. That's what it does. Trust me, I know. Oh, I know. Anyway, if there's fluid on the inside, honestly, what we typically will start with there is well, it depends on how much it is, but usually we say we want you to take some Mucinex. Mucinex will have a tendency to dry up some of that extra fluid that may be inflammatory in nature, and then it'll be gone. Sometimes if there's a little fluid there, we might be able to aspirate that or to remove it at the time of an embryo transfer. But I wouldn't cancel a transfer because there is fluid there in the very beginning. It sort of depends on when it is. So first thing I would tell you is Mucinex, and let's see if we can't make that fluid dry up and be gone by the time it's time for your transfer. NYC Sexy Babe. Oh, I like that. I'm going to send you an extra wave there. Hi to Lindsay. Another Lindsay. We've got Gabby Stalinsky. Professional. We've got Kylie Ann Diaz. Good afternoon. Can PCOS cause multiple LH surges? I am supposed to transfer Monday, hoping I don't have to cancel. So the LH surge is what happens that causes your ovary to release its egg or to ovulate. That LH surge is what triggers your ovulation. So when we give you a trigger, we are doing something to either mimic or force that LH surge. In PCOS, your LH levels tend to be higher. But to see multiple up and down, not specifically, no, because one of the issues that goes along with PCOS is actually more an issue of anovulation, that you don't ovulate on your own. So I wouldn't be surprised to see that the LH level may run a little higher in you, Kylie, but multiple ups and downs, I wouldn't expect to see that so much. Hello to Mrs. Celia Kennedy. 4 IUIs, 1 pregnancy, early miscarriage, 4 frozen embryo transfers, 1 pregnancy, currently miscarrying. Well, I am sure sorry to hear that. So, the first thing I have to wonder about is, kind of there's lots of different things that can go into that picture hormonally, mechanically, what's happening inside the uterus. Sometimes people will tell me, well, we did some IUIs and we were never able to get pregnant. So that must mean that something is wrong, doesn't it? Is that what that means? That something is wrong because we weren't able to get pregnant with the IUI? And I would say no, that's not what that means, because IUIs probably have anywhere from about a 4 to a 9 or probably a 5 to a 9% chance of being able to get you pregnant. Whereas with IVF, we can offer you really up to a 60% probability kind of per embryo, as opposed to, 9% chance per cycle. So, IUI is a better treatment option than doing nothing at all. IVF is always going to be the fastest path to pregnancy and the most reliable. So, Celia, I would say that's, probably worth a kind of a more detailed conversation. But I will tell you, and I think everyone else who is with us this afternoon will share with you, that we do share in the grief and in the frustration, and our hearts and our thoughts and prayers are with you as you're going through this difficult time. So God bless, and really sincerely all the best. Hello, Rashmi. My day 3 ultrasound had 12 follicles, but my doc said that these are more for an AMH of 1. He said I may have less. Well, so, I'm not 100% sure what you mean there, but I would tell you that, when we look in the beginning of a cycle and we count the number of follicles that are there, we call that an AFC, an antral follicle count. And it used to be that was a measure that we could do. If we looked at the number of eggs that we see in the beginning of your cycle, we may be able to make some prediction over, how your body is going to respond to stimulation meds for IVF. As it turns out, the AMH level is much more predictive of how you will respond. But so, for example, just because I see 12 follicles in an antral follicle count at the beginning of your cycle, that doesn't say to me that means that you're going to have a minimum of 12 eggs or a minimum of 12 follicles after after stimulation. So, maybe I think that might be what you're asking. So does it give us some prediction? It can. If there are less than 5 follicles, then we might consider that to be a low antral follicle count. But I would certainly say 12 sounds very promising. And frankly, so does the AMH of 1, if that's indeed the case there. Hi to Arlene and Kelly and Ashley and Flaky, L. Higgins and Whitney. Let's see, Sarah Manara. Hi, Sarah. Can you do IUI or IVF with fluid in your uterus? I had baselines and have a history of endometriosis. I've had a previous laparoscopy. No one has mentioned anything like that. Well, so, if you're at the beginning of your cycle and you do a baseline and there's some fluid that's in the uterine lining, most of the time that's still blood that's associated with, as you're sloughing off that lining along with your period. What becomes more important is fluid that's in the lining at the time of either an embryo transfer or an IUI. So as we get closer to that juncture, when we look with the ultrasound, that would be the point that we might say, hey, take some Mucinex, because Mucinex will help to dry up that fluid if indeed it's there. Let's see what else we got here. Hi, Hopeful in 2023. How many days before an embryo transfer do I start my doxycycline? Well, so it's usually, I think, about day 6 or 7 of the cycle. So it's during, I don't know that there is any real specific evidence based on that. It sort of happens about a week or 10 days or so before you're going to do your embryo transfer. And what's the reason for the doxycycline? Well, we are taking a catheter, the embryo transfer catheter, and we're taking it through the vagina and we're putting it into the cervix, up into the uterine cavity in a place that should be sterile. So really what we want to do is we want to decrease the amount of bacteria that's around in the cervix that catheter may have the ability to drag up to the inside. So typically 7 to 10 days kind of before transfer. But again, not a lot of strong evidence that the timing makes all the difference in the world there. Let's see what else we got going on here. Shanty Dib. I had a blighted ovum last month. So sorry to hear that. How long should I wait to do another transfer? Well, so once you've had a pregnancy loss, or once your pregnancy loss has been identified, there's typically a couple of things that we can do. One is that you can have a D&C. The D&C is where we physically remove the portion of the pregnancy that's inside the uterine cavity. Now, when we do that, we can't remove all the cells that line the uterine cavity. They have to kind of slough off on their own. But that's what a D&C is, a dilation and curettage, or what some people call a dusting and cleaning. That's a D&C. Or we can wait and let the pregnancy pass on its own, which is certainly less interventionist. We don't have to put our hands on anything, but it means that, we don't really know when it's going to happen. And it may happen in the middle of the night, or it may happen at work, or it may happen when you're walking down the aisle in the grocery store. And so a nice middle ground there is that we can use medication. And the medication is called misoprostol, and that will cause your body to pass the tissue on its own. Usually once that's happened, I generally tell folks, once you've gotten your next regular cycle, because there's still going to be some time that the body has to help to clear out the remaining tissue. So once you've gotten your next regular cycle, then your hormones have all gotten back to normal. You have cleaned out, you have mowed the grass on the lining that's on the inside there, and then generally it is safe to proceed with another transfer. We used to tell people, we want you to wait for 3 months. Guess how much science is involved with that? 0. There is no magic to 3 months or 2 months. Really, honestly, the data says as long as the tissue has cleaned itself out, that the uterine lining has reset, which is what happens with the very next cycle, then you can proceed. Let's see. Let's go back to the Facebook side here. We got a bunch more questions. I saw a quick one right there. What does it mean, a low AMH? This comes from Paige. AMH is the anti-Mullerian hormone, and that is what we consider the measurement of ovarian reserve. So we are born with all the eggs we'll ever have, and over time we start to lose those eggs. In fact, we lose a bunch before puberty, but after puberty, each and every month we start losing eggs. By the time we're 35, we lose about 10,000 eggs a month, which is unbelievable. When those eggs are all gone, that's what we call menopause. And as the numbers start to get lower, they are reflected by the blood test known as the AMH. And as the numbers get lower, that tells us that the body is not going to respond as well to the stimulation medication. And so that's why I say that that number is predictive of how you will do with the IVF medicines. They say it does not correlate with your ability to get pregnant on your own, but a lot of times people are having difficulty getting pregnant. We go and we check the blood test and find that the ovarian reserve is low, which suggests that perhaps even in the remaining eggs, there's some issue also of egg quality, meaning to say the stability of the genetic material, the DNA that's in those eggs. So that's what that means. Allie Smith just got your retrieval report, 15 frozen embryos. Holy moly. I agree. Congratulations there, my friend. That is awesome. Ethereal is asking, what is the ideal lining for transfer day? Well, we really don't need to test it on transfer day because what's more important is the lining when we start your progesterone. So that's what we call the lining at progesterone start. The uterine lining gets thicker and thicker and thicker as a result of the estrogen that your body makes or that you are getting. And we want that lining to be ideally, we'll call it 7 millimeters thick. Now, it probably continues to grow even after you start your progesterone, but it also starts to compact. It starts to sit more tightly as it's getting ready for the pregnancy to be inside. So we don't measure it on transfer day because the number that you get on transfer day is really not interpretable. Let's see. If a person has an umbilical hernia, do you suggest getting that fixed before pregnancy? You know, a lot of women in pregnancy will have an umbilical hernia. In fact, it used to be my practice that if we were able to, we'd kind of oversew that and fix that at the time of a C-section if somebody was having a C-section. What a hernia is a defect in the tough lining of the abdominal wall. What kind of lining is that? Well, if you're eating a piece of steak, it's kind of gross to think about, but if you're eating a piece of steak, it's the gristle. There's basically a hole in the gristle. And in the case of the belly button, that is what causes an outie as opposed to an innie. And no, that is not medical terminology, but umbilical hernias and physiologic hernias in the belly button can happen just, very commonly in pregnancy. And you start to be able to kind of feel the thinness in the belly button as the baby is on the inside kind of pushing and the belly is becoming more distended. The risk from an umbilical hernia is that you can get a piece of the fat that lives inside the body, inside the abdominal cavity, and that's called visceral fat. Usually it comes from a structure on the inside that's called the omentum. You can get some omental fat that gets stuck in the defect in the hernia, and that's called an incarcerated hernia because it can get stuck in there and it can block the blood flow going to it, and that can cause that piece of fat to start to want to die, which causes a big kind of pain syndrome. Fortunately, that's not all that common an occurrence. So I don't necessarily recommend, this comes from JC, I don't necessarily recommend a hernia repair before pregnancy because a lot of times that hernia will just recur in the pregnancy. Now, there are other types of hernias. There's an inguinal hernia. There is what's called a ventral wall hernia, and that's where the abdomen itself starts to separate kind of at the midline. Those kind of things might be a little bit more significant, and maybe you want to think about getting that kind of thing fixed before pregnancy. But belly button hernias, umbilical hernias are really pretty common. Julia is telling us, hi, Julia, I am 38 years old. I have diminished ovarian reserve, and my husband has a high degree of DNA fragmentation in the sperm. The sperm motility, and the sperm count are slightly lower. We did 2 IVFs in Canada, where each time we had 5 embryos that seemed good at day 3, and then by day 5, most of them arrested. Is this more a result of bad sperm or bad egg? And what can be done to keep that from happening again? Well, Julia, so my guess is it's probably both of those things. It's both sperm and egg. You have diminished ovarian reserve and you're pretty young. You're 38 years old. So that tells me that there probably is some issue with egg quality. What can we do to try to improve egg quality? There's a list of supplements I can give you that are associated with improving egg quality for people with diminished ovarian reserve. Feel free to message me through Instagram at what is my handle, at Randy Fink MD. We can do that. Omnitrope is a help. The estrogen priming we talked about can be a help. Metformin as a medication in the IVF world is the same as a supplement that's known as inositol. Metformin is very helpful for egg quality in IVF. So these are things that we can do specifically for egg quality. as it pertains to the rate of DNA fragmentation. There is an add-on that costs $200 at CNY that's called Zymot, Z-Y-M-O-T. And feel free to, Google that. They have a nice website where they kind of explain what they do. Zymot is a mechanism that is designed to help to select the better sperm, i.e., the sperm that have a lower degree of DNA fragmentation. Think about it this way. It's a tunnel, and you put all the sperm in on one end of the tunnel, and based on the obstacle course that they have to swim on the inside, only the best and the strongest, and of course the best looking and the best senses of humor, come out the other side. And in this way, it helps the embryologist and the andrologist to be able to select the best sperm. And again, in theory, sperm that has a lower degree of DNA fragmentation. The other thing that you can do for DNA fragmentation has to do with the frequency of ejaculation. The more your husband ejaculates, the lower the sperm count in each given ejaculate, but the higher the quality sperm. So there may be a scenario where we say, well, instead of abstaining for 72 hours before collecting for IVF, that he actually ejaculates daily leading up to that collection for IVF. So these are some kind of general ideas there, and I hope that will help you guys. Devin McKenzie is here. No question, just 31 weeks pregnant because of CNY Colorado. Can't wait to bring him to visit. I can't wait to see that baby, Devin. Congratulations. Boy, that is fantastic. Jessica Huffman asks, how much risk is factor V Leiden in having an embryo transfer? So we talked a little bit before, about things that can cause those tiny blood vessels to develop clots in the uterus. And factor V Leiden is one of those things. That's called a hereditary, meaning to say it's passed along in families, thrombophilia. Thrombo means clot. Philia means you like to make these clots. Well, you may not like to, but your body has a tendency to do that. We treat that. We treat that at CNY. So everyone gets Lovenox. Just about everyone is recommended to have Lovenox. That's probably the better way to say that. But what that means is that we are trying to prevent that sort of thing from happening. If you are known to have factor V Leiden, then you will absolutely be on Lovenox, a blood thinner, and generally speaking, you will stay on that blood thinner up until about 36 weeks of pregnancy, because blood clots and how those blood clots can travel can end up resulting in problems, very significant life-threatening problems further on down the road. So you will definitely stay on your Lovenox. We've got a few more minutes for some questions here. Let's see. M. Afer, I have my second retrieval on November the 3rd, and we decide to do one more retrieval. Is it normal to start follistim and stimulating 8 days after that retrieval? Don't you have to wait for the period? Well, so you're doing something that is called it's called a duostim. And a duostim is where you have your retrieval, and anywhere from 4 to 8 days later, you start your next stimulation. Duostims can help in some circumstances for people to increase their yield. Another thing we do, if we wait until you get your period, that's called a back-to-back retrieval. Different people have different opinions on duostim versus back-to-back. I prefer back-to-back. Dr. Kiltz, for instance, loves to do duostims. But really what happens there is that you're stacking cycles. You're putting them one on top of the other, which means that the medication that you used in the first cycle is going to continue to help you retrieve eggs in the next cycle. And that, as a rule, is a good thing. Let's see, Mrs. Pittman, I had a miscarriage in August, and I saw you guys. I decided to take a break until January, February. Is there anything I could do on my time off to help for a successful transfer in the future? Yes, I think there is. Really, it's so easy to take this handful of vitamins. It's a prenatal, it's CoQ10, it's some fish oil is generally a good idea, omega-3. It's vitamin D, it's vitamin E, and it is L-arginine. We talked about those a little earlier in the hour there, but Mrs. Pittman, that I think is the best thing that you can do to try to make your body better equipped to sustain the pregnancy. Let's see. What else does a reset? This comes from Embrace the Hard? Does Receptiva test for adenomyosis or just endometriosis? It is just for endometriosis and what is known as endometritis, which is a chronic inflammation in the lining of the uterus. So that's what it tests for. Golly, you know what? It looks like we are going to end up running out of time here. And I think we could probably all stay here for another couple hours, but you don't fall asleep. And hey, I don't mind if you ever want to stay for longer. I think eventually one of the social media things will kick us off, but it is always a pleasure to be with you. Infertility is not your book. It is not your novel. It is not the title of your story. It is merely a chapter in that book, and we are here to help you to rewrite it. Remember what I said before: choose love, choose kindness, choose friendship, and most importantly, choose happiness. It's great to see all of you. We'll look forward to seeing you next week. Until then, I'm Dr. Randy Fink, live from Colorado Springs. Have a great week, everybody. God bless, and we'll see you next time. Good night.